This program is brought to you by Emory University.
Our speaker this morning is Akanksha Agrawal. Akanksha is one of our first-year fellows in the clinical track. She is originally from India, and that is where she did her medical school. She came to the United States, did her residency, where so many of our fellows did their residency at Einstein Medical Center in Philadelphia, where she was a chief resident last year. And as you can see, she's going to talk to us today about an interesting topic, one we haven't heard much about at this particular conference, valvular heart disease in pregnancy. Akanksha.
Thank you, Dr. Williams. Dr. Book mentored me through this talk, so she couldn't be here today, but if there are any major questions, I'll be happy to answer them or transfer her over for answers as well. So I'll be covering the epidemiology of valvular heart disease in pregnancy, hemodynamics of pregnancy, etiology, risk stratification, and how important counseling is for these patients, some of the specific pathology and their management, the choice of prosthesis and anticoagulation during my talk. The trends of pregnancy-related mortality have been on the rise in the United States in the last couple of decades. About 1 to 3% of pregnancy are complicated with the cardiovascular disease, but it leads to about 10 to 15% of mortality, cardiovascular disease itself in pregnant women. The causes for mortality in pregnancy include, as you can see on the left side of the page, are more so the obstetric causes. On the right side of the page are the cardiovascular diseases and cardiomyopathy. And over time, especially in the last decade or so, they have increased to a higher number than they were before, now leading to about, like I said, 10 to 15% of mortality during pregnancy. Why is this so? Many patients with significant valvular heart disease often are not aware of their diagnosis until they become pregnant. And it is during pregnancy, the hemodynamic changes that happen during pregnancy that make someone manifest with the clinical symptoms. The cardiac output, the stroke volume, and the heart rate rise during pregnancy, and the total peripheral vascular resistance and the hemoglobin decreases during pregnancy. I have divided this further into hemodynamics during pregnancy and during labor and delivery. So during pregnancy, the cardiac output increases by about 30 to 50%. The increase in stroke volume is more than the increase in heart rate. The systemic vascular resistance decreases, and it's at the minimum somewhere at the end of the second trimester, and then slowly rises again. There is physiological anemia, where the expansion in the plasma volume is more than the expansion in the RBC mass. And altogether, all the above conditions lead to an increased flow through a stenotic valve, leading to increased gradients and making a patient symptomatic. Also, not to forget, pregnancy is a hypercoagulable state, prompting concern, especially in patients with prosthetic valves. With the hemodynamic changes that happen, which is increased heart rate, increased plasma volume, increase in cardiac output, and decrease in SVR, the stenotic lesions, aortic stenosis and mitral stenosis, do not tolerate that well. There is an increased flow through the valve, which is already stenotic, leading to increased gradients, like we said before, leading to higher left atrial, left heart pressures, and making a patient symptomatic with heart failure. Regurgitant lesions tend to be tolerated well because of the decrease in the peripheral vascular resistance. There is decrease in afterload, which leads to a better forward flow, and hence regurgitant lesions are tolerated better. There's also concern, and some of the studies have shown that during pregnancy, because of these hemodynamic changes, the prosthetic valves have an accelerated rate of degeneration. And also, obviously, there are challenges with the anticoagulation, with the mechanical valve, which we will certainly be discussing later. Now, during labor and delivery, again, the cardiac output rises, 30% about in this first stage of labor, but 80% in the immediate postpartum. And why is that so? Because with each uterine contraction, about 300 to 500 ml of blood is being auto-transfused from the placenta into the systemic circulation. And that is one of the major reasons why there is sudden increase in cardiac output. And also the systolic blood pressure increases with each uterine contraction. These shifts peak at about 24 to 72 hours after delivery, and that is also a crucial time when the epidural agents which are in the system. Epidural agents, most of them also cause vasodilation, further causing an afterload reduction, which might have been helpful in the case of regurgitant lesions, but not so in the stenotic lesion. And the risk of thrombosis, which was there throughout the pregnancy, increases further postpartum, and this is the time when it peaks postpartum, sometime in the first 6 weeks of pregnancy. Now, there are certain findings in a normal pregnant women which might be confusing with heart failure symptoms or heart failure signs. A normal pregnancy can have fatigue, decreased exercise tolerance, palpitations, lower extremity edema, and dyspnea. An examination might reveal systolic murmur just because of the high flow, continuous murmur because of the mammary souffle, split S1, distended neck veins with A and V veins, and lower extremity edema. Going on to etiology of valvular heart disease. This depends from area to area. In a developing country, about 90% of valvular heart disease in pregnancy is rheumatic in origin, whereas in a developed world, about 30 to 50% of it is congenital heart disease. So the causes include congenital, rheumatic, myxomatous mitral valve disease, prior endocarditis, some valve disease which are associated with systemic disorders like Marfan syndrome, SLE, inflammatory vascular disorders, radiation-induced vascular disease, and prosthetic valves. I've further divided the etiology into LV inlet and LV outlet, more so going with the physiology of it. There has been a registry, it's called European Registry of Pregnancy and Heart Disease. It includes countries like Europe, North America, Egypt, Russian Federation, and they found that about 60 to 63% of valvular heart disease was mitral stenosis per se, and about 23% of it is aortic valve disease. The remaining 4% is what is the right-sided lesions and right-sided pathologies. Aortic valve lesions, most common being congenital bicuspid valve, rheumatic heart disease, connective tissue diseases, like we said, the Marfan, Ehlers-Danlos, Turner syndrome, prosthetic valve, and prior history of endocarditis. Same are present in mitral valve, including mitral valve prolapse and hypertrophic cardiomyopathy with a systolic anterior motion and a tethered mitral valve related to dilated cardiomyopathy. RV outflow obstruction due to pulmonary valve lesions could be congenital, could be Noonan syndrome, post-op tetralogy of Fallot repair, or pulmonary regurgitation, also related to tetralogy of Fallot, prosthetic valve, bioprosthetic, and there are certain conditions which, if present, complicate the scenario, like pulmonary hypertension, impaired left ventricular function, presence of heart failure, and aortic dilatation in the case of bicuspid aortic valve, and Marfan syndrome, and aortic coarctation. Going forward, I'll be referring to the ACC-AHA guidelines from 2014 and also the ESC guidelines from 2018. From a practical standpoint, I might not have much experience in this field, but Dr. Book mentioned that she usually refers to the European guidelines as they are more concise. Let's discuss a case, and we will more so look at the imaging and the management part of it rather than the history and physical. So a 32-year-old gravida 2 parity 1 who has known to have rheumatic mitral stenosis presented to the Grady Clinic for a 4-month follow-up for a cardiology follow-up while she was 4 months pregnant. She was asymptomatic, and her previous pregnancy was a spontaneous vaginal delivery in Ethiopia. Those are her parasternal long axis and apical 4-chamber view, showing a typical hockey stick appearance of the mitral valve, left atrial dilatation, kind of preserved LV function, and mitral stenosis. Her mitral valve mean gradient was 14 millimeters of mercury, and she was classified as in the report moderate to severe, but more so severe rheumatic mitral stenosis with a mitral valve area of, I would say, moderate to severe, mitral valve area of 1.3 centimeters square and a mean gradient of 14. She did have severe left atrial dilatation like we saw, and importantly, she did not have high pulmonary artery pressure. Now the questions here are, how would you risk stratify her? What is the appropriate counseling that you would be giving her, and would you be intervening or not intervening in such a scenario? For the preconception risk stratification, there have been multiple scores, CARPREG, Zahara, and modified WHO. Modified WHO being used most frequently. There has been a study which shows that the WHO risk assessment was better in terms of calculating the risk of cardiovascular disease during pregnancy with heart disease in comparison to the other two scores. And this is for all cardiovascular diseases, including congenital heart disease, acquired heart disease, and valvular heart disease. What does the modified WHO score state? It divides the cardiovascular conditions into grades, into classes 1 to 4. 1 being the least significant, and 4 being the most. 1 is when there is no detectable increased risk in maternal risk or mortality. 2 is small increased risk. 3 is significantly increased risk, where expert counseling should be provided and management should be done in an expert center. And 4 is extremely high risk. The ESC guidelines further have made a class which is modified WHO 2 to 3, where there is a range of small to significant increased risk. And we'll see in the next slide as to why is it important to risk stratify these women is from the counseling decision, follow-up, location of delivery, and everything. These are all the lesions listed in this classification, and I have highlighted those which are valvular heart disease per se, since the talk pertains to that. Having a small or a mild pulmonary stenosis is modified WHO 1. Having a mitral valve prolapse is also class 1. An unrepaired tetralogy of fellow is modified WHO 2, which is a small increased risk. We'll move to class 4 now, where severe MS and severe AS are part of class 4, and bicuspid valve having more than 50 mm of aortic root dilatation is class 4. Any native tissue valvular disease which is not class 1 or class 4 falls in 2 to 3 category, and also bicuspid valve with an aortic root dilatation of less than 45. All mechanical valves are WHO class 3, which reminding you again, significantly increased risk of mortality and morbidity, but pregnancy can be continued. And this is how it's the rate of event and the counseling have been outlined as per the guidelines. For someone with a modified WHO 1 lesion, there is a 2.5 to 5% cardiac event rate, which increases to about 40 to 100% if they have a class 4 lesion. Counseling, yes, for everyone, but if it's a class 3 or class 4 lesion, they need expert counseling. Care during pregnancy should be at a referral hospital or an expert center as they move higher in the class of WHO. The follow-up during visits, which is pretty important for us as a cardiologist, and following these patients as an outpatient. For someone with a lower degree of lower class of lesion, you might follow them once or twice during pregnancy or once per trimester. But for someone with a severe AS, severe MS, you want to follow them monthly. And then the location of delivery, which could be a local hospital if they have a lower class of modified WHO class of lesion, but if they have a higher class, they need expert center. Before pregnancy, if a person is suspected to have a valvular heart disease, they should have a thorough clinical evaluation and a transthoracic echocardiogram. And all patients who are found to have severe valve disease should undergo pre-pregnancy counseling by a cardiologist who has expertise in managing valvular heart disease during pregnancy. I forgot to mention that in the class 4, in the guidelines, it ideally states pregnancy is contraindicated, but if pregnancy is followed, then it should be managed as class 3. We'll be discussing some of the left-sided obstructive lesions, and we'll go back to our case after we discuss the mitral valve stenosis. So mitral stenosis is the most common acquired valvular lesion in pregnant women and most common cause of maternal death from cardiac causes worldwide. And why is that so? Because when the heart rate increases, the diastolic filling time for the left atrium and left ventricle decreases, which causes increased left atrial pressures and causing pulmonary hypertension, pulmonary venous congestion. So an asymptomatic person becomes symptomatic. This is how the ASC classifies mitral valve stenosis. Something something important to be mentioned here that in pregnancy, because of a high output state and because of increased gradients in general, because of the hemodynamic challenges that are there during pregnancy, the reference measurement is planimetry. Gradients are also taken into account, but it has been shown that planimetry is more concordant with the manifestations. What does it do to the mother and the baby? Mild lesions are pretty well tolerated. Moderate to severe are poorly tolerated. Heart failure occurs in about 1/3 to half. Arrhythmias, AFib, and SVT occur in about less than 15%, and mortality in 0 to 3%. Low in Western countries, higher in the developing countries. It causes prematurity in 20 to 30% of babies, intrauterine growth retardation, and fetal death. And how can you manage? If a person is symptomatic with heart failure or has a pulmonary artery pressure of more than 50, then you give them beta blockers. If they are not getting better with beta blockers, you do diuretics. And the diuretics typically should be used in low dose as they can lead to placental hypoperfusion, oligohydramnios. Also, all these women, if they have AFib or a LA thrombus or a prior embolism, need anticoagulation. That's a class 1 indication. Anticoagulation should also be considered in someone with moderate to severe MS and spontaneous echo contrast in the left atrium, or if they have a large left atrium, or if they have low cardiac output or CHF. And then who would you intervene? So before pregnancy, if someone has a severe disease, severe mitral stenosis, then you perform intervention before pregnancy in an ideal scenario. You would do a percutaneous balloon mitral valvotomy. If someone has mild MS, you just continue medical therapy. If someone has moderate MS, that is when you look for their symptoms and exercise tolerance. If there is decreased exercise tolerance, you perform a procedure, and if no, continue medical therapy. Now, during pregnancy, most of these patients are managed just with medical therapy first, and if they are refractory to medical therapy, that is when you would perform balloon valvotomy or commissurotomy. If they do not have any symptoms, you just continue with the medical therapy. So pre-pregnancy, significant MS, even if asymptomatic or a valve area of less than 1, should get intervened. During pregnancy, ideally performed after 20 weeks once the fetus is viable, and to be done only if the systolic pulmonary artery systolic pressure is more than 50, or patient has NYHA 3 or 4 class symptoms after they are on optimal medical therapy, or after they are on medical therapy for the MS. If a person has mild MS, or they have only class 1 or 2 symptoms without pulmonary hypertension, they can go through a vaginal delivery. If they have a higher class of NYHA or they have pulmonary hypertension, one should have a cesarean section. And because there is an incidence of about 15% of having AFib, it is important to note that AFib it is very important to control atrial fibrillation in these settings with beta blocker, if not getting better with digoxin. And a lot of times these patients also need cardioversion, where Dr. Book wanted me to especially emphasize that in a 3rd trimester pregnant women, doing a cardioversion is is pretty scary, and also that you might want to intubate and extubate just for a minute because of higher risk of aspiration with a gravid uterus. You always try to place anteroposterior pads and avoid being close to the abdomen as much as you can. Let's continue with our case. Reminding you, our case was moderate to severe mitral stenosis with the normal pulmonary artery pressures, who was asymptomatic and did not require any medical therapy during the pregnancy. She tolerated the pregnancy pretty well. She did get monthly injections of benzathine penicillin, which is part of the rheumatic heart disease treatment. She did get frequent cardiology follow-ups and underwent a vacuum-assisted vaginal delivery at 38 weeks and delivered a healthy baby. Let's discuss another case. This is a 30-year-old lady who is gravida 1 and her first pregnancy. She is 23 weeks pregnant. She has no past medical history, comes to Atlanta from India about 3 years back. She presented to the ED with shortness of breath, orthopnea, and cough, and was treated as pneumonia in the outpatient setting. And here is her parasternal long axis view. Again, a pretty typical hockey stick appearance of the mitral valve, slight left atrial dilatation, and here are her mitral valve gradient, which might have been a little overestimated, but final report said a mean gradient of 21. The mitral valve area calculated here from the VTI was 0.4. This is her tricuspid regurgitation jet, and she had severely high pulmonary artery pressure. Her report read EF of 50 to 55%, mildly dilated left atrium, severe mitral valve stenosis, mild to moderately increased right ventricular systolic function, severe TR with an estimated RVSP of 127, and severe pulmonary hypertension. Now, management for her differs from our first case because she has high pulmonary artery pressure, she's symptomatic, and she falls in modified WHO class 4. She was counseled. This is her presenting at 23 weeks. She was started on treatment with beta blockers and diuretics with no improvement in her symptoms. She was counseled as to this would be the next step would be to go through an intervention, and this is the time when there is high risk of fetal morbidity and mortality if going through the pregnancy. She underwent a balloon valvuloplasty. Her gradients improved post-balloon valvuloplasty from 21 to 6.5 immediately post-valvuloplasty, and 7 to 8, 1 week post balloon valvuloplasty. She continued with the pregnancy and had a cesarean section for cord prolapse at 36 weeks and delivered a healthy baby. Moving on to aortic stenosis. The main cause of aortic stenosis is bicuspid aortic valve in United States, followed by rheumatic heart disease. Like I said, in a developing nation, rheumatic heart disease more common. The risk of hemodynamic compromise and heart failure are high during the second to third trimester. Like we discussed, that is the end of second trimester is when the SVR is the least. Cardiac output has been on the rise as well. During labor and delivery, and 24 to 72 hours after delivery, as that is the time when cardiac output peaks again at the 24 to 72 hours after delivery. Adverse maternal and fetal outcomes increase with the severity of AS. And it is recommended for all patients who have aortic stenosis who are asymptomatic with severe aortic stenosis to undergo an exercise testing to make sure that they do not develop symptoms of aortic stenosis or have an altered blood pressure response during exercise. Because if they do, the management differs. What does it do to the mother and baby? Aortic stenosis also leads to heart failure in about less than 10% if they were asymptomatic before, and 25% if the patient was already symptomatic. Atrial arrhythmias, rarer in comparison to mitral stenosis, but still present, and again, rare mortality. There is also a very low risk of aortic dissection if the aortic diameter is less than If it is less than 50, low risk. If it is higher, higher risk. It leads to preterm birth, intrauterine growth retardation, and low birth weight in 20 to 25% of babies, and miscarriages and fetal death in about 5%. So if a patient comes in already pregnant with aortic stenosis and is symptomatic, then we would do preload reduction with cautious use of diuretics and restriction in activities. Who would be intervened, and this is going back to pre-pregnancy, anyone with symptomatic severe AS should get an intervention pre-pregnancy. Anyone who had asymptomatic severe AS but had an exercise stress testing which was positive should undergo intervention, and an asymptomatic patient with an impaired LVEF, which is EF of less than 50, should undergo intervention pre-pregnancy. And how would you deliver these babies? If it is severe and symptomatic, a cesarean section. If asymptomatic but severe, individualize the treatment, whether C-section or vaginal delivery. And if it's a non-severe AS, they can proceed with vaginal delivery. We'll talk just 2 slides about coarctation of aorta, and the reason we are doing so is because a lot of times coarctation of aorta is associated with a bicuspid aortic valve. This is in the setting of discussing the aortic stenosis itself. About 6 to 8% of patients with congenital heart disease have coarctation of aorta. And usually, if these patients have been repaired during their early childhood, they proceed with the pregnancy, or they proceed to adulthood without any complications. The females who have aortic coarctation are expected to reach childbearing age if they have had the repair, or if they have native coarctation, but that was hemodynamically mild or unrecognizable. Important thing is to make sure all extremities blood pressure is checked to make sure that if a patient has pre-existing hypertension or has been labeled as eclampsia or preeclampsia, to make sure that there is not a secondary cause of hypertension. There has been a study, and this was one of the largest studies looking at coarctation of aorta. They looked at 74 women who were pregnant who had coarctation, and they found that about 57% of them had bicuspid aortic valve disease. How did these women do during pregnancy? Pretty well. One woman died of aortic dissection at 36 weeks, but others, no other pregnancy-related complication was seen. So this is just to keep an eye out if a patient has hypertension, to make sure that we keep our eyes open to look for a secondary cause like coarctation of aorta, and then to make sure that women who do have bicuspid aortic valve to get to look at their ascending aorta and the descending part of the aorta to make sure that they do not have coarctation of aorta. And that leads us to our next part, which is how would you survey what parts are there in the surveillance of anyone with all these stenotic lesions. All these women should get an echo once per trimester, with the 3rd trimester echo performed around 32 weeks of gestation, which is the peak of the hemodynamic load during pregnancy. In someone who has congenital bicuspid valve, like I said, they should get imaging of their ascending and proximal aorta, given the association of coarctation and the aortopathy. And there is a slight risk of genetic transmission of LV outflow tract malformations, which justifies the performance of fetal echocardiography in AS due to bicuspid aortic valve. I'm not entirely sure if this is being done at our center, but this is one of those scenarios when you would do fetal echocardiography. Going on to regurgitant lesions, like I said before, because of the hemodynamics where the systemic vascular resistance decreases, the regurgitant lesions are better tolerated because of improved forward flow. The regurgitant lesions could be rheumatic, congenital, or degenerative in origin. And we would be discussing less of regurgitant lesions and move to prosthesis pretty quickly. Mitral and aortic regurgitation cause heart failure 20 to 25% of the times in pregnant women, and also have ascending aortic diameters should be measured for a risk of, because of the risk of dissection during pregnancy, especially in patients with bicuspid aortic valves. Babies, it leads to intrauterine growth retardation in 5 to 10%. And the basis of management is mostly diuretics during pregnancy for fluid overload if these patients do become symptomatic. Any person who needs an intervention for a severe mitral or aortic regurgitation should get it pre-pregnancy. If the pregnancy is continued with a severe lesion, if their symptoms become refractory to medical therapy, they should get an intervention during pregnancy. Now, this being said, for all these lesions where we're doing intervention during pregnancy, there's if they do get a surgical aortic valve or a mitral valve repair, there's a 30 to 40% chance of fetal mortality, and that is why we always have been emphasizing on intervention pre-pregnancy if someone has a severe lesion. They should be followed every trimester in mild to moderate and more often in severe regurgitation, going back to the modified WHO. If they are class 4, every month follow-up. And these patients tolerate vaginal delivery pretty well, the patients with regurgitant lesions, and the reason being, like we said before, epidural agents are themselves vasodilating as well, which further drops their SVR, which improves which decreases the afterload and improves the forward flow. So overall, regurgitant lesions should be delivered with vaginal delivery with epidural anesthesia. Just a slide about tetralogy of Fallot, where a repaired lesion was a WHO class 2, which is pretty well tolerated. Cardiac complications occur in about 8%, and arrhythmias and heart failure are the most common symptom, like any other lesion. Thromboembolism and endocarditis are rare, and the problem that occurs here is dysfunction of the RV and moderate to severe pulmonary regurgitation, which are risk factors for a poorer outcome in a patient with tetralogy of Fallot. And fetal growth restriction in the baby if the pregnancy is continued. These patients should be followed up every trimester. In women with severe pulmonary regurgitation, they should get a monthly or a bi-monthly cardiac evaluation. If there is RV failure, diuretics, bed rest, and early delivery, or a transcatheter valve implantation to be considered in those who do not respond to conservative treatment. Moving on, we'll be talking about prosthetic valves and choice of processes and what you choose, and then mechanical and anticoagulation for the mechanical valves. The top horizontal are all the mechanical valves, the St. Jude bi-leaflet, the Medtronic tilting disc, the Carbomedics, and the ONX valve. The bottom on the left side are the prosthetic bioprosthetic valves, and on the right are the transcutaneous valves that are implanted. It's an important decision to be made pre-pregnancy if a woman needs a bioprosthetic, if a woman needs a mechanical or a bioprosthetic valve as to which one should be implanted. A mechanical valve has excellent hemodynamic performance. It also offers long-term durability, but it comes at a risk of increased maternal and fetal mortality and morbidity, which is much, much higher with a mechanical valve as compared to bioprosthetic valve. A bioprosthetic valve has better chances of an event-free pregnancy, and this has been well studied in multiple studies. It has lower hemorrhagic events, but it is associated with high risk of structural valve deterioration, a risk of going through the pregnancy with this dysfunctional valve and eventually needing a reoperation. In one of the studies, about 50% of patients who had bioprosthetic valve implanted at less than 30 years needed a reoperation at 10 years post-valve implantation. But that being said, the risk of maternal fetal mortality and morbidity with mechanical valves and anticoagulation is so high that it is a class 2B indication to put a bioprosthetic valve in women who desire pregnancy. So overall, bioprosthetic is better if pregnancy is desired. And why is that so? Like we discussed, there are maternal and fetal risk with mechanical valve. As per a study, the chances of event-free, and this is the ROPAC registry data, the chances of event-free pregnancy with a live birth was 58% in a mechanical valve compared to 79% with bioprosthetic and 78-79% with women who have heart disease but no bioprosthetic valve, but no valve prosthesis. Hemorrhagic events are much, much higher, 23.1% with mechanical versus about 5% in someone with bioprosthetic. And the risk of valve thrombosis, which is very high in mechanical valve, and then this further delineates as to the way you treat those patients with mechanical valve as to how the risk of thrombosis varies. Someone who gets warfarin has a 0 to 4% risk of thrombosis in comparison to heparin or low molecular weight heparin, which is at a much higher risk of thrombosis. So the offspring or the obstetric risk, there is a risk of miscarriage, where warfarin had slightly increased risk of miscarriage in comparison to low molecular weight heparin or unfractionated heparin, and this was dose related. There's a risk of embryopathy, which is limb defects, nasal hypoplasia, and this varies from about 0.6% to 10%, and this is also dose related. And the reason I'm mentioning here dose related is because the guidelines as to how you would manage anticoagulation depends on the warfarin dose during pregnancy. There is risk of fetal intracranial bleeding with the mechanical valves because they are on anticoagulation, and also hemorrhagic complications in mother. So overall, because of all these complications of bleeding and thrombosis, mechanical valves should not be implanted, and prosthetic valves should be preferred in someone who is desiring pregnancy. The embolic events account for about 10% of maternal mortality, and that is why we're going to discuss as to how to anticoagulate the patients with mechanical mitral valve if they are pregnant. These are following are the two slides from ESC guidelines where, depending on the warfarin dose that a patient requires, your management changes. So if a patient has been requiring warfarin at a dose of less than 5 milligrams, the effect of embryopathy or the fetal risk are lower. The embryopathy risk is about 2 to 3% if they have a dose of warfarin which is less than 5. And if they are taking a dose of more than 5 milligrams of warfarin, the risk of embryopathy is about 8 to 9%. And because of that, if a patient has been requiring warfarin more than 5 milligrams during because of their mechanical valve, they should, during the organogenesis phase, which is 6 to 12 weeks per se, should be switched to either unfractionated heparin or low molecular weight heparin. During the second, third trimester, they can continue either the low molecular weight heparin, unfractionated heparin, or even continue warfarin. At about 36 weeks of pregnancy, any women who, whether she was taking warfarin less than 5 or more than 5, should be switched to unfractionated heparin or low molecular weight heparin, which should further be switched to heparin, the unfractionated heparin, at around the delivery time. The heparin is usually turned off about 4 to 6 hours before the planned delivery and reinitiated at 4 to 6 hours after the delivery. For someone who's been requiring less than 5 milligrams of warfarin, they should continue it's a class 2A recommendation to continue warfarin during the organogenesis phase as well, or can be switched to low molecular weight heparin or unfractionated heparin, and then continued with warfarin during the second, third trimester. Again, switch to either unfractionated heparin or low molecular weight heparin at about 36 weeks, and then during peri-delivery time, heparin only. Low molecular weight heparin, though, has been outlined in the guidelines pretty well, but there are multiple restrictions and practical limitations on using low molecular weight heparin because the anti-factor 10A levels need to be monitored, which in a lot of settings are a send-out lab. They have to be monitored. They have to be monitored pre-dose and the peak level, and it has not been studied well as to which of the pre-dose anti-10A levels or a peak anti-10A levels which is more related with the best anticoagulation effect. A level of 0.8 to 1.2 is what is, for the anti-factor 10A level, is what is aimed at. And this is what the ACC-AHA have from their 2014 guidelines, that if a pregnant patient has a mechanical valve, they should get the therapeutic anticoagulation, which again depends on the warfarin dose, like we have discussed. Less than 5, more than 5. Less than 5, continue warfarin either, or you can switch to low molecular weight heparin. And if their baseline dose is more than 5, then they must be switched to low molecular weight heparin, which is the main point from these anticoagulation slides. And the reason being there is a higher risk of fetal embryopathy. During their second or third trimester, they should be continuing warfarin along with aspirin, and before a planned delivery, again switching to unfractionated heparin or before delivery unfractionated heparin, and that is to be stopped 4 to 6 hours before and after delivery. The key points from my talk: expert counseling is crucial in patients with significant valvular disease, and this depends on how you have risk stratified them, for which we use the modified WHO classification. Stenotic lesions are usually poorly tolerated in comparison to regurgitant lesions, and we looked at the hemodynamics. Why is it so? The bioprosthetic valves are preferred over mechanical valve, though there is a risk of deterioration of the valve. But still the maternal morbidity and mortality from anticoagulation and mechanical valve is much higher, and hence bioprosthetic are preferred. Transcatheter approach has been reported in few cases and might be promising in the future as to a reasonable option for pregnant women, but right now not a part of the trials, at least yet. The choice of anticoagulation for the mechanical valve depends on the trimester and the dose of the warfarin that was being used. And overall, it's a multidisciplinary approach, and you need a team for the heart, a team for the baby, and a team for the mother for the management of these patients. Thank you, and I would be happy to take any questions.
Something that I should have probably looked up myself at some point, but what is the effect of beta blockers on the uterus, and is there preferred beta blocker in a pregnant woman over the other ones?
Yes, so beta blockers cause uterine relaxation, and predominantly it's the beta-2 receptors that are present in the uterus. And that is why during pregnancy, it is advised to use beta-1 selective blockers. Metoprolol is commonly used, atenolol less so, but metoprolol is the go-to drug. Yeah.
Yeah, that was good. I don't have any specific questions. I was just going to ask about, I was going to give a little plug about hypertrophic cardiomyopathy, which you didn't touch on, but I thought it was something I might mention. Not that you should, because you covered the more important things with more valvular disease. You mentioned earlier, so Say it's generally well, even though it's quasi-stenotic lesion, because it's not fixed stenosis, it's generally well tolerated during pregnancy, except those times when it isn't, unfortunately. Like a lot of things with hypertrophic cardiomyopathy, it's very unpredictable. And a lot of the people you think are going to cruise, you'll have problems with, and vice versa. The people that tend to get the biggest problems, besides those that have developed LV dysfunction, who would, in my mind, be sort of a class 4, sort of contraindicated group, are those that develop arrhythmias, which are very unpredictable. Those that develop AFib or ventricular arrhythmias during pregnancy, and it's hard to predict who's going to do that. So again, we generally just watch them closely, and that's the biggest thing we sort of worry about is the development of arrhythmias during pregnancy. The obstruction stuff, because again, their volume status sort of increases, that actually a lot of times will get better during pregnancy. The LVOT obstruction is generally, those patients tolerate it fairly well, so.
I think just the biggest thing with those patients is that they get identified and they get to the appropriate center where they can get the expert care. I think for us in general cardiology, it's always a challenge when you happen to run into one of these patients out of the typical environment. Thankfully, in Atlanta, we can kind of touch base with experts in the field and get them what they need. But if they are not identified, that's where you really run into trouble. And I don't think it's so much the coarcts, it's the patient, the adult congenitals that seem to do well for a period of time and then kind of go into denial in their 20s and present pregnant in late 20s, and that's the first time they've been seen in over 10 or 12 years, and those are the ones that really present the challenges. But I guess the first thing is you see them, but then you've got to make those calls. I certainly need to, when I see that kind of a patient, have to get on the phone to adult congenital, say Northside and other places that have more expertise in dealing with these.
There's something else. The other, back to the beta blocker, for hypertension, I think propranolol is often the one they prefer, maybe not for AFib and rate control type situations. And then the other just point with hypertrophic cardiomyopathies, for women with hypertrophic cardiomyopathy, I would say I don't know the exact percentage, but a significant number of them get diagnosed during their first pregnancy, right? Because a lot of times that is their first point of care with, the medical community since they were a teenager often. So that is frequently when people get diagnosed with hypertrophic cardiomyopathy is sometimes in the first trimester of their first pregnancy. Tough, because a lot of times, obviously not a disease that hasn't been present, at least phenotypically, since birth, so.
And that is also the scenario for most of the other lesions of valvular heart disease. They present during pregnancy because of those hemodynamic changes. That's it. Thank you.
The preceding program is copyrighted by Emory University.